of a 50% as a cutoff. Anything below 50, that's a deficiency. Above 50, that's unlikely to be deficient. There are situations where you need to do some molecular measurements or identification of mutation before going for defining the deficiency. If we go to molecular test, both the factor V Leiden and the prothrombin, the type of anticoagulants, be it in the tube or when the patient is on heparin, it may affect the testing and cause some heparin inhibitor for DNA testing, and the methodology, type of methodology, and the sensitivity of methodology may affect the result of this. So to make it more easy, I had selected 5 clinical situations, and I'll try to go quickly through these 5 clinical situations where we can see the impact of thrombophilia testing on treatment of these conditions. The first one is secondary prevention following provoked VTE, secondary prevention following unprovoked VTE, primary prevention and relative of VTE, and primary prevention in females going or considering estrogen, and finally primary prevention in female relatives who are going for pregnancy. So before proceeding further, just give you a snapshot of different preferences, and you can see that the highest preference here we can see is the factor V Leiden, which is in between 2 to 7. We had done multiple studies in Saudi Arabia, and we are talking in a range of around 4% in the country. So we are about the middle. While in most Asian country, it's below, even below 2, reaching to 0. So if you look at the preferences, you can see that different preferences depends on the type, and these preferences even are different according to reports from either patients or relatives during acute phase or during pregnancy. I will not go in details because of the sake of the time, but I'll take you directly to those 5 conditions and try to see what are the evidence that we have to support testing or not to test. The first one is the secondary prevention following provoked VTE. Thrombosis following a major provocation, we give 3 months, and that's what recommended by the ACCB and most of the countries, and there is a short-term relative risk of reoccurrence of 0.5. So let's compare to those absence of identification provocation. So if we have a recurrence of 0.5 or less than 0.5, now it's being considered very low risk after provoked VTE. And in many studies, and I had quoted only 2 of these studies, and the ASH, in large prospective registry offered patients with VTE the opportunity to be screened for hereditary thrombophilia. They found that very low risk after provoked and did not differ between the patients with hereditary thrombophilia or no thrombophilia. Another large study, controlled study, they looked at the risk-benefit balance favoring time limited to anticoagulation regardless of presence or absence of thrombophilia. The downside of this one, which has been highlighted by ASH 2020, that there is a potential for patient harm. And that potential for patient harm is if you have a false read or false interpretation of the results and you put the patient for unnecessary risk of bleeding for something not documented. And that's because of that, the ASH had recommended against screening for thrombophilia. So that's the first condition. The second condition is the prevention following unprovoked VTE, and this is where really the most acceptable, I will not go through again, I'm looking at the time, the most acceptable situation where you need to test for, but that should be in a situation where these tests will be used. There are many, again, larger studies looked at the value of the testing, and they nicely documented that or proven that the anticoagulation or testing for thrombophilia would lead to better anticoagulation of these patients. But again, the pros of testing is negative test of thrombophilia may falsely reassure the physician. Now this patient, and particularly if the patient has a family history, which is considered the most important factor for recurrence is the family history, not the thrombophilia. So if you have a negative thrombophilia and unnecessarily you stop the anticoagulation, now you affect the patient on the other side. So this is the second situation. The third one, which is the relatives of VTE patients, and that's a very common question. Once we identify a patient with factor V Leiden mutation, do we need to screen for the whole family? And that comes from a couple of studies. I will show you the first one, which is a large screening study of family members of VTE patient, revealed that asymptomatic carriers of a hereditary thrombophilia defect were at excess risk of thrombosis, with risk varying by disorders, depends on the type. But they found that the family history of thrombosis alone carries the most important risk, even absence of identifiable thrombophilia risk factor. Again, they noted that negative thrombocytopenia does not equate to normal VTE risk and does not or should not prevent you to consider thrombophilia prophylaxis during acute phases. In another cohort of a study, which was over about 9 years, the rate of provoked VTE was higher in group with thrombophilia 0.58 compared to 0.24 in those without it. Again, here now, what is the recommendation is do not test for thrombophilia in asymptomatic family members of patient with VTE or with hereditary, unless there is something will be done to do for relatives, for prophylaxis. This is again another interesting area which usually we get asked about, which is for female patients, relatives who wants to start estrogen. What is the recommendation? She has a family history of thrombophilia. Do we need to screen for thrombophilia? And the answer comes from a couple of studies focused on testing of thrombophilia in general female population, which has suggested little utility and risk of cost effectiveness or a lack of cost effectiveness in these patients. And in that study, which is nicely calculated how much you need to test to prevent a BE or VTE in around 100,000 carriers is $300 million. A lot of money to prevent one. And it could have been done much easier by one question. Do you have a family history? Extended family history of question. Do you have it or not? That could have saved. And the British guidelines recommend again is screening for patients who are going for estrogen, unless there is a strong family history. Okay. Finally, the pregnancy is an area where itself there is an increase 5 to 10 times the risk of thrombosis. So do we need to do screening for females who have a relative with thrombophilia? The answer comes again from many studies. Women with a prior VTE that was unprovoked or provoked by pregnancy or OCP merit prophylaxis regardless of the thrombophilia status, and that had been confirmed in many studies. Okay, so that comes to the conclusion of these 5 situations. The first one, do not perform thrombophilia. The second one, the provoked, do it if that will help you to make a decision about the duration. Regarding the third one, don't perform the thrombophilia testing in asymptomatic family members because that would not add much. For the primary prevention for estrogen, do not perform it unless, except for a woman for estrogen use has a first degree relative with VTE, a known hereditary risk factor, then you may have some benefit of doing it. And finally, for pregnancy, the recommendation not to do. Now, we talked today and heard about the biomarkers, the personalized, the how to decide based on biomarkers. I think one of the areas where in hematology not progressing very well is to defining biomarker to detect who is not based on the genetic background, who will be more entitled to get thrombosis. And unfortunately, we did not move forward too much in this regard, except for some studies, and just because of the time, several risk models had been suggested. D-dimer. And I got the D-dimer because the D-dimer has many studies. The most recent one, which just been published in 2023, showed serial D-dimer level have the potential to identify patients at high risk and impact the treatment. Thrombin generation, there is some work ongoing. The fibrin monomers, the use of ultrasound to look at the residual is again another area. Just 1 second, just to tell you that there are issues with the thrombophilia, with all genetic testing, that we don't give it much time, which is the psychological, emotional impact on the results. And in a NICE study, they looked at, or in a NICE meta-analysis, they looked at 6 studies, the impact of the thrombophilia on these patients who are young and may use it for a long time. And as you can see, most participants were found to be carriers, were satisfied with knowing when to use it or not. A participant expressed concern that being carriers of thrombophilia could cause stigmatizations and problem with obtaining insurance, and that's another issue which was emerging. And finally, participants felt that thrombophilia testing was less serious than genetic testing for breast cancer risk or non-genetic testing. And finally, I would like to tell you what happened to my case, just to conclude. She completed 12 months of anticoagulation. During that course, she was started on warfarin because she had mildly elevated lupus anticoagulants. Everything was negative. Lupus was 1.3. The cutoff is 1.25, so just marginal. So because of I repeated that without anticoagulant, because we know that anticoagulant can affect, and it came to be negative. So I put her on rivaroxaban. She developed severe menorrhagia, iron deficiency. She needed to receive multiple iron IV to keep her hemoglobin up. I switched her to apixaban, less tendency to bleeding, still continued to bleed. Menorrhagia in her age of 16 is not encouraged. Then the family came and they said, we know that everything is negative, but we don't want her to continue an anticoagulation. What you would advise us? So I put all the cons and pros of the situation, and putting in mind that we did serial D-dimer 5 times and all negative from the first one, that's reassuring a little bit. I discussed with them all the possibility, and then we came in combined conclusion that we will stop the anticoagulation, but put her on regular follow-up with D-dimer. And by that, I will end my talk. Thank you.